Pleasant good morning. Welcome to another informative and educative edition of the program Broadway to Health, an hour-long program brought to you by the Ministry of Health, of course, designed to educate, inform, and empower you about health-related matters. Well, today is Tuesday, November 25th, 2025, and driving you through this edition of the program, Angela Noor, and
Melvin Stewart.
and of course, we have Charles Adlin here with us, making sure that you get access to this program through the Ministry's official Facebook page. And Isa Yiba is here streaming live from ELBC Angle. So, however way you are joining us this morning, wherever you are joining us from, we'd like to say welcome. It's always good to be here with you. Well, this morning, we'd like to take a moment to send special greetings to the Minister of Health, Dr. Louis Porter, our able deputies, assistant ministers, and all of the staff of the Ministry of Health. I'd like to say thanks in a special way for your continual commitment to shaping the health agenda of our country. Well, this morning we have invited in studio our able health expert in person of Jonathan Flomo. That's Dr. Jonathan Flomo, the program manager of the National AIDS Control Program at the Ministry of Health. Dr. Flomo is here this morning to provide valuable insights, educate, and inform you more this morning about Liberia's response to HIV. What are the efforts being made so far when it comes to the country? What that they are doing to make sure that HIV remain under control. So we'll take a very short break to be right back with the details. Don't become a parent before your time. Welcome back and thanks for rejoining us. Good morning, Melvin.
Good morning, Angela, and good morning, Liberia. It's good again to be on the flagship program of the Ministry of Health. We are always gratified to do what we do for Liberia.
Okay, it's always good to be here with you. So welcome our guest this morning.
Yeah, Dr. Jonathan Flomo, his name is a household name. Yes, he's one of the strongest in the health sector of our country. Back in the days in Bon County, he did extremely well at the Bon County Health Team. He came from Atisano as well, and his impeccable character matters a lot. So we are grateful that we have him here at the national level. And I think this is his fourth time or third.
I mean, the place is like a
so
home though.
he's a friend. He's always open up to come and share his experience with the public. So this is something awesome. I want to say congratulations to you guys for always showing up.
Thank you, ma'am.
How are you doing?
Yes, I'm doing okay, and we are happy to serve our country and to ensure that the peace-loving people of Liberia have good health services available for them, particularly when it comes to HIV.
Okay. Angela, you keep the ball rolling.
Okay, so at the Flomo, how is the National AIDS Control Program? I mean, in general, how is it work?
Yes, generally we are doing very, very well at the national program. We know there are challenges, but I think we are making significant progress as it relates to our global targets and reaching the Liberian people with HIV services based on WHO recommendations. And one of those things I must flag now is, when we had the first case of HIV in 1986, that prompted the establishment of the National AIDS Control Program in 1987. So since 1987 up to now, it is this 2025, the draft budget, we are seeing clearly that the National AIDS Control Program is reflected in the national budget. So this is something very commendable, and I think we have to, flag it so that the public can know that there's some progress being made when it comes to HIV interventions in Liberia and that of hepatitis B interventions. So the draft budget carries HIV, and the national program, we are responsible for not only the HIV portion but also STI. So we also work closely to ensure that our people have access to hepatitis, viral hepatitis services, including other STIs. So I just thought to flag this as a very important point that
And we will have to look into it maybe for the next 5 minutes. Then we get to the real issue. But you talk about 1987, and since 1987, the National AIDS Control Program has not gotten anything from the national budget or the draft budget. Like now, the 2025-2026 the draft budget, you have something there.
Yes, so over the years, we have been working closely with, Central Ministry of Health. They've been providing support. But what I mean is to have the National AIDS Control Program reflected as a national program in the budget. That is something that
it is not under the Ministry of Health.
No, so there are programs under the Ministry of Health, but particularly the critical programs like HIV, TB, malaria is the first time to see the National AIDS Control Program reflected in the budget. So for me, I see it as a very strong commitment, and I really want to appreciate.
And it is on your watch.
Definitely. So I'm happy.
You have a heavy burden to carry.
Yes, definitely, and want to extend sincere thanks and appreciation to our Honorable Minister, Dr. Luis Cotto, for the support and the entire senior management team. This is something that is very commendable, and we are happy that it's a gradual process. So it just shows a level of commitment when it comes to HIV and STI interventions in Liberia.
Dr. Flomo, what is the what in that draft budget? What is the tone of your own? What did you see in the reflected budget?
So we see for hepatitis B vaccine interventions, we have 150,000, and for just the National AIDS Program, we see 100,000. So for me, it's not just about the amount. But the picture to see the national program being reflected, it shows that
recognition is
recognition, and also the level of work we are doing and the need to do more. So we want to expand our coverage as we are doing to ensure that the people of Liberia have adequate services when it comes to HIV and hepatitis interventions in Liberia.
Okay. Congratulations once again.
Thank you.
Today we are focusing more on Liberia's response to HIV. In general, but before we, go into the broader discussion about Liberia's response to HIV, let's firstly clarify the information about the increase in HIV cases from 34,000 to 36,000. Does this mean that there is no control, or what exactly does this figure mean?
Thank you, Angeline. When I was surprised to see, on the social media, there are a lot of information going around HIV. But again, we have the world governing body that we refer to as UNAIDS. There is what we call the spectrum estimate. So every year, they come up with spectrum estimate. But then every other year, we meet in other countries to sit together, and then we come up with these numbers. So there's just scientific calculations that are carried out to ensure that every country can have an idea whether of your country data, whether people are positive or they are being tested, they are not being tested, just to give you a rough estimate of the numbers. And these calculations come up considering the population of the country, considering other surveys, other assessments are carried out, and they look at other global indicators, and then the calculation is done to just give you an estimate. They're almost like when you ask somebody to build your house and you say, I need estimate, it will be underestimated, it will be overestimated. So it's just about an estimate. So this is a trend of information. Let's start from 2022. 2022, the data shows that UNAIDS estimate shows that we have 34,431 persons living with HIV in Liberia. 2023, we retain the same number. 2024, we went to 33,768 persons living with HIV. And now the last one they did was in 2025, which was launched on July 9. It shows that we have 36,000 persons living with HIV. It doesn't mean those are people who are positive, or that's the actual number, or it's an estimate considering all of the ramifications around HIV data in your country and other global indicators, considering also your country population. So that's the number 36,000. Now, of that number, I can safely say to you that 3,700 are children.
Wow.
Yes. So they estimated that 3,700 children are living with HIV in Liberia. The rest of them are adults. Now, what have we been doing? We have currently the global target of 95, 95, 95. That every country under the watch of the UN wants to see every country reaching what we call 95, 95, 95. Meaning, 95% of those living with HIV in your country, they should know their status. Meaning, we have to test people. 95% of those who know their status should be placed on treatment because the WHO recommendation says when you test, you should treat. They tell 95 say those who you are placed on treatment, you have to monitor the treatment outcomes because if you give somebody medicine and you cannot monitor it, means you give them poison. So they tell 95 say 95% of those who have been placed on treatment should have suppressed viral load. Now, where is Liberia? Against the 36,000, I can simply tell you, we are at 86%. We are identified 86% of the people who have been estimated the 36,000
to live with the virus.
Yes, we already have them. We are identified 86% of those people. And those we identified, we have placed 99% of them on treatment. And those who have been placed on treatment, 95% of them have suppressed viral load. And even of those who are suppressed, 75 to 80% of them, their viral load is undetectable.
Why?
And
Why?
It's undetectable because they are very compliant to their medication. And when you are undetectable from the scientific standpoint, it means that you don't have the quantity of the virus to infect somebody. So it means that even if you have sex with somebody without using condom, you cannot infect them with HIV. So that's the problem.
Even if the person has the virus.
Yes. If this person it will do a test, it will test your viral load and it's undetectable. Meaning the quantity of the virus within you that is capable of causing a disease, you don't have that quantity. It doesn't mean you don't have HIV, you still have HIV. But because of the medication, it being compliant on the medication. So those are the things that we are doing. So it's not just about the number, but also to know what are the interventions and what we have those people under control. Notwithstanding, we still need to do more because there are other people who actually do not know their status. So the idea now is that how can we encourage people to know their status, to be tested? Because once you know your status, we place you on treatment early, definitely. We transition from what we call TLE, that's the medication, the tenofovir, lamivudine, and evivarin. We transition to the newest combination, which is the tenofovir, lamivudine, and dolutegravir. And as I speak to you, we are not yet seeing any resistance to the dolutegravir combination. Meaning, once you are HIV positive and we start you on medication, we expect within the first 6 months you should have suppressed viral load. That's the reason the first time we initiate your viral load is after 6 months when you are initiated. And after that, every year we do your viral load at least one to monitor the treatment outcomes, whether you are following. Because if you are complying with your treatment, we expect your viral load to continue to go low.
While on the treatment, are they home, when they are homes? Do you go and do checkups and see how they are coming on, or you just forget about them and wait for the 6 months to elapse before you before you go for a further checkup?
No, we are following up on these people. We have our clinicians, all of the facilities. We have ART clinicians. We have other PEs, peer educators, and peer navigators that are in the field that are visiting these people. They are placing calls, so we follow them up. We follow them to make sure, you are compliant. Like for instance, if you go 6 months and we see that your viral load is still very high, it means you need adherence counseling. Apparently, you've been defaulting, you're not taking the medicine on time, you're not very compliant. So we have people who will also talk to you, to counsel you, to be adherent to your treatment, because the goal is that people who are negative, we want to keep you being negative, so we have other preventive interventions that we are carrying out. People who are already positive, we want to ensure that you have suppressed viral load and your viral load become undetectable, because it will be another form of prevention. Because if you are undetectable, somebody who is HIV positive, it means that you don't have the quantity of virus that can cause infection for another person. So it's another form of prevention. So that's the goal, to ensure that people can live a very, very healthy life.
In these kinds of works you do, in all of what you opt to do, especially so when the pronouncement was just made recently, it has huddled, it has made a lot of people afraid. But people will say, Liberia, in our Liberian way, we only get to stay 1 day time. But people are also pointing fingers at communities that you, from the angle of the Ministry of Health, specifically pointing hands to communities that are mostly infested with the HIV virus.
So, that was very sad.
That is, especially the Dupont Road community, what is being mentioned all over the place, and several other communities.
That was very sad anyway, for somebody to just come up with their own numbers, or pointing finger, stigmatizing, certain communities. We saw that to be very, very bad. And honestly, we need to desist from those kind of habits. When it comes to HIV, it's confidentiality. Our data are not disaggregated to that extent that you just go to say Dupont Road is like this, you can find that anywhere. So that's one of the information that people, I mean, was very misleading.
So that is false.
Very, very false. Very, very false. We can't do that. I mean, our data, there's no way you see our data disaggregated to the extent that you see, or Duko Road community get this, or GSA Road community has this. No, that was completely unfair to the Liberian people. So we want people to desist from the habit of just, spreading false, information when it comes to HIV. We are very passionate about what we do and to ensure that our clients and more people, so that you can be, you can have that encouragement to come and be tested. And the sooner you do it, the better it is, because you are placed on treatment, the medication are absolutely free. Those are medications that are very expensive.
What did that worry you as an institution when the news of filtering in the air that you from the National AIDS Control Program or the Ministry of Health accuse these communities of pointing hands to these communities, not just Dukot Road, the Shara community, even Bon County mentioned, and all of that with numbers attached to them. Sign all of the counties in fight. But I think when I was reading up, the lowest county I saw on that list, Babulu County, I said, wow. They said because Babulu is in the forest. They don't really worry you from the National AIDS Control Program.
Yeah, it did, because we know the way information has spread, people understand it. I had other colleagues understand during that period. I was in Durban in South Africa when, after I moderated our international section. I saw, one on Facebook, I just saw, the HIV information, people just respond. So, I said, what's this? Then friends started sending, or messages to me, oh, what is this true? Is this true? I said, what is this? So I thought immediately I came, I had an engagement in Popolu. I left this morning just to come on the show to make sure, we can provide the best information to our people. And I want to categorically, dispel that rumor that there's nothing of such. The numbers you see, they are false, they are misleading. And it's not from the national program. Those are not our information. The categorizing, stigmatizing communities to say, oh, you have this, you have that. No, that cannot be.
Your only issue here is 36,000 persons are living with the virus in Liberia.
Yes, so it is estimated at 36,000. So I just gave the clarity to say, yeah. So what's the information behind the 36,000? That's the reason I said 86% of the 86,000, they are people that we know already. We have identified those people already. 99% of those people that we have identified, they have been placed on treatment. They are on a medication. 95% of those who we have placed on a medication, I tell you, currently they are virally suppressed. And 75 to 80% of those people, their virus is undetectable. To take a lot of work that we are doing at the Ministry of Health to ensure the safety of our people. So that's the reason you even find families. Somebody with HIV positive will have their family, their children will be HIV negative because of the interventions we are carrying out to ensure that we can provide the best services for our people, to make sure we identify people in time, and to make sure when it comes to counseling, we do pre and post test counseling to ensure that you are adherent to the treatment, and to ensure that you stay free and open to us, so that we can have this implementation. HIV is a lifelong condition that you have to go with. So we don't want to stigmatize anybody.
You said 3,000 kids, children are living with the virus.
Yeah, estimated
3,000. The remaining numbers, how many males, how many females in it?
So for the numbers we have, if you subtract the 3,700 from 36,000, you have 32,300. Of that number, you have 21,000 that are females, and you have 11,300 that are male. Wow. And then another thing that came up that is very good to say here is the issue around the females. The women just have the condition. The women HIV. The women very high. So we must make this clear that females have good health-seeking behavior as compared to males. On the other hand, we also have compulsory testing at antenatal care. So once a woman is pregnant, you must be tested for HIV. And one of those things that we are even trying to do, currently, we have the HIV syphilis dual test that we do. So every pregnant woman is now tested for HIV and syphilis. We are trying to launch the triple elimination effort, wherein a pregnant woman will be tested for HIV, syphilis, and hepatitis B. Because that's where the global conversation is going to ensure that we have the triple elimination effort. Let me go to the numbers when it comes to the males and females. Okay, Melvin. So just to clarify, the argument around, why female and why male. In 2024, we tested 67,156 males, and we had 2,850 positive for HIV. 67,000. Now, for female, we tested 307,000 females, and we have 5,883 positive. Do the math. If you have more males coming to the facility, the males number will even double that of the females. But because males have poor health-seeking behavior, you know, at home, I mean,
the males go hustle now. They go to the market. They go to other workplaces to get food for the family.
Yes, and let me tell you, in Southern and Eastern Africa, because I mean, I'm part of most of the HIV international groups. So we're having this conversation to see what can we do to ensure males visit the hospital to be tested. So they did an interview in Eastern and Southern Africa. The male said, what we normally do is that we have to go fetch food for the family. I mean, I'm not available, and then the clinic are closed on Saturday and Sunday. So in certain countries in Southern and Eastern Africa, the Ministry of Health intervened, and they had a clinic open on Saturday and Sunday for males to go there so that they can seek care. Men also don't go there, even after opening the clinic at that time. So there are just a lot of excuses when it comes to men and seeking help, except it is something that is life-threatening. But the females, we can barely witness on a daily basis, or they will tell you, so now I want to go check, I need to go do my lab. You know, I woke up this morning, I'm not feeling too fine, I need to go do my lab. How often do you hear male talking about going to lab? Melvin, we are all gentlemen. When lab is imaging, they say that people visit the facility. No, those things don't happen. So imagine testing 67,156 and getting 2,850, and then testing 277 females, and we got 5,883. Maybe do the math. It will definitely tell you that the issue around male seeking care, it will have more men going. We will double or triple the number of females because males have poor health seeking behavior. But the few males that went, we saw the increase in positivity with the numbers. So it's not just about, maybe stigmatizing all the females, no, because they have good health seeking behavior, and whenever they are pregnant, it is mandatory that they get tested.
Okay, so at the FOMO, why it is true that we have a lot going on? I mean, we'll talk about that when it comes to interventions and other things. We also don't want people to any kind of the virus. So the health-seeking behaviors and things that we are talking about, what are some factors that are contributing to this condition, and what people need to do? Actually.
Thank you, Angeline. So there are several preventive interventions. As I said from the beginning, we want people who are negative to continue being negative, and people who are already positive for us to provide the best care so that they cannot be able to transmit the disease to even their unborn children. So that's the reason we have all of those interventions. But now, for prevention, there are several other ways. As always, we say you should use condom. Use condom. The next thing we say, initially, we did not have this intervention when it comes to the pre-exposure prophylaxis. We had a post-exposure prophylaxis, meaning like, for instance, rape victims, people who work in health facilities, they got pricked, or by a needle that, from an infected person. So we gave you the post-exposure prophylaxis. So they are antiretroviral drugs that you take for, 28 days. But now, in Liberia, we have what we call the pre-exposure prophylaxis. That is also being provided by the Ministry of Health. We have it. The pre-exposure prophylaxis, there are ARVs that you take prior to going into an event. Like, for instance, those who are involved in risky behavior. You take the pre-exposure prophylaxis, even if you should have an intercourse with somebody who is HIV positive, you cannot contract HIV. Those are preventive interventions that we are carrying on now. So we are working closely. I mean, before the U.S. government stopped work order, we are waiting on a proposal to have the long-acting PrEP, which is the injectable that you just need full injection for the entire year. I mean, you are safe on HIV. So there are a lot of things that we are doing to ensure that people who are negative continue being negative, and people who are positive, for us to ensure that they are compliant with their medication, and then to make sure they can have a better with their family.
So tell us more about the different interventions we carry out.
Yeah, so as I said, for prevention, our message is that we want to have people, we don't want to have new cases. That's the message.
Is that possible?
Yes, it's possible because of compliance. Like, for instance, because the high stigma and discrimination with HIV, I mean, to find people just going to the facility, sometimes it's difficult to say, I want to be tested. We also have what we call HIV self-test. You know what I mean? We can provide HIV self-test. You go in your room, in your bathroom. We show you how to go about it. You just swap, and then it reads the result. If you are negative, you are negative. If you are positive, the message here is you have to visit a health facility, because before we say you are positive, it means that you must follow the 3-test algorithm. We do 3 testing before we say this person is HIV positive, because we want to make sure that you are HIV positive. So we also have the HIV self-test. So for people who are, at risk, high risk, we give you HIV self-test because you don't want to go to the facility. You go in your room and you do your test. Negative, you negative. If it is positive, we name you go to a facility for them to do your 3 tests. If those 3 tests comes positive, all of them come positive, then we say you are HIV positive.
So if 2 came positive, 1 came negative.
Yeah, so we have the protocol, and then we follow that. So it is this is science, very exact. If we do it and then it comes in that way, we say go and come back in 14 days for us to do another test. So we have the whole algorithm that we follow for both pregnant women and also the entire population. So those are things that we are doing to ensure that people who are negative be negative. Meaning, if we test you and you are negative, we give you all of the options or continue to use condom. We have the pre-exposure prophylaxis, which is PrEP. And sometimes the reason we don't go more for creating more demand when it comes to the commodity is that these are commodities that are expensive, and sometimes about moral hazard where people feel because the commodity is free and is available, people just come and get it.
Yeah.
So we need to target our intervention to consider those who are at high risk. Melvin, take for instance, if somebody is a female sex worker, if you're a female sex worker, maybe, and you have a prevalence around maybe 10.1, and then the general population with a prevalence of 0.9 to 1.1, who are higher risk, the person who is still at 10 with the prevalence. So it means that we will make sure people who are higher risk, they get involved with all of the preventive interventions. So those are things that we do. We are working closely with all of the high risk population, everybody, to ensure that the preventive interventions are available. So some of these communities, we don't have to go, people go to facility and just be testing. No. What we do is that we talk to you, we provide you, we sensitize you, and then you are provided the HIV self-test. You go and swap, you conduct the test. If you conduct the test and then you are negative, it means that you are negative. If you are positive, we say no, you are not yet positive. You are considered positive when you go through the 3-test algorithm, meaning we have to test all 3. We use the determine, the SD Biolan, and the Unigo. When they are all positive, now we say you are HIV positive.
So let me ask you, Dr. Flomo, if a gentleman went to the hospital and they got tested and got and came positive, do you request them to bring their partner? Because why the gentleman is on the test, why the person is on the treatment, and the partner is not on the treatment, and they think the person could get reinfested?
So what we do is that when we have what we call index testing, that's another form of testing that we do to identify more cases. Again, as I said, our own goal is we want to prevent the issue of new infections. So we do all we can to ensure that people who are tested positive, we follow not just their wife, but other relatives and people who are close to you. And it is voluntary, but there are techniques that are used to ensure that we reach out to people who you have interacted with to ensure that they are also tested. We are not going to say, oh, Melvin got positive, so we are coming to test you because he's positive. No. We have techniques that we use to ensure that we reach out to people who are at high risk to ensure that they are tested. And the reason we do that is, again, in responding to public health interventions, what you want to do first is to identify those with the condition. If you want to prevent the spread, it means that you must first identify those with the condition. So that's the reason we want to ensure that we continue to do testing. So people who are positive, Melvin, yes, we also test their family with their consent. But again, we are not going to say, because I told you the confidentiality, the peace. We're not going to say, oh, they are Melvin got positive, so Melvin said that you're a friend, so we came to do testing. No, there are techniques that we use to come to you, and then with a proper counseling, we have people who are trained, properly trained to counsel you. And then once you are pre-test counsel and post-test counsel, you find that even if that person came positive, it is very easy for them to accept the result, and also, agree to take their medication. So those are the things that we are doing currently.
That's it.
So for the female sex workers and that of the children, what specific intervention you have in place for them? Because for the female sex workers, they'll always go back because that's what they do to survive. What specific intervention you have in place, especially when it comes to trying hard so that you don't have further transmission and things like that?
So, as part of our intervention with female sex workers, we work very, very closely with female sex workers. Very, very closely to ensure that they are placed on PrEP, the pre-exposure prophylaxis. So if they are on PrEP, meaning even if they decide to have an intercourse or are using condom, it means that they cannot get infected because they are already on the pre-exposure prophylaxis. So we're working closely with them. We have what we call the peer educators and peer navigators that are working with them. We also have their peers because it is easy to work with your peers. So we have people among them who are also female sex workers that we are working with closely, that are working with all of them to ensure that they get tested, to ensure that those who are positive are placed on medication, and those who are negative to continue being negative by giving them condoms. We provide condoms. We also provide what we call, as I said, the pre-exposure prophylaxis. And that's a medication that when you take and you have intercourse, you cannot get infected once you follow the protocol. So they are trained to that, and we are very engaged with those people.
So for turnout, because stigma is one of the things that preventing people from showing up when it comes to testing and all those different interventions that you have for them to even take advantage of the opportunity. When it comes to turnout, what does it look like? Do you have more people showing up for the services that you're providing, especially for the one that will prevent them?
Yeah, sure, Angeline. So I think you see the numbers that we call. Just 2024 we tested, around almost 350,000 people. So to tell you that yes, we are making significant strides to ensure that we reach more people. We also have, community outreach. We also have community interventions. As I said, we are even using the HIV self-test. I know it might be sounding very new to you. We have HIV self-tests that, for people who feel they don't want to be part of, the testing, and they feel that they want to keep that information confidential. So we also just sensitize you on how to, conduct the test, and then we give it to you, go in your house, you do it, because the data has shown that no one will sit on a positive result for more than 28 days. So whenever the HIV self-test, you do it in your home and it says positive, whenever you walk around a ring behind your ear, so the people told you that when it's positive, you have to go to the facility for them to do testing. You're not yet positive until the 3-test algorithm, you can follow that, and then they say you are positive. So the person will move around for some time, but then eventually they will learn at the facility to say, they're not going to say, I did HIV self-test and I came positive. But we monitor that indicator by seeing the number of persons who go to the facility for voluntary testing and counseling. If you have only 2 persons coming to your facility A for voluntary testing and counseling, and after we sensitize the community, we gave them HIV self-test, and the women who did that HIV self-test, we came back and then we saw in the facility 2 persons were coming for voluntary testing and counseling, but now we're seeing 50% coming for voluntary testing and counseling. It means that is a factor of the HIV self-test.
Okay. So where can people go actually to get tested? People listening, some of them might tempted, want to go and get tested, especially for the self-test. Where can people go to get that self-testing, equipment or whatever you call it?
So there are a few interventions, like I said, when it comes to the HIV self-test, when it comes to the pre-exposure prophylaxis, that those preventive interventions, we tailor it to people who are at high risk, because we don't want to create, that demand, and after creating the demand, it becomes, difficult to have to serve almost everybody who, come for pre-exposure prophylaxis. Whenever you talk about pre-exposure prophylaxis, you find a lot of people interested in knowing more about the pre-exposure prophylaxis, because how can I prevent myself? You understand? So we have those services, for people who are at high risk. Notwithstanding, there are people who, intermittently they become, they get involved into risky behavior. Those are things that we also do. But in our health facilities, they are testing available. You go to our health facility, we have clinicians there are available to do your test. And everything around HIV, as I said, it remains free. So we test you free, provide medication, and even doing your lab in terms of the viral load.
They do the monitoring.
It's also, yes, we monitor you, so it's also free. We provide health counseling for those who, if we notice that your viral load is still, very, very high after you take the medicine, we expect that is due to you not being compliant to the treatment. So we have counselors who will talk to you and tell you the importance of, being compliant to your medication.
Years back, the National AIDS Control Program distributed condoms across the country to various institutions, hospitals, churches, malls, and schools, to sensitize, especially students, to tell them the danger that this virus poses to their lives. Are you people still into the vanguard?
Yeah, so we conduct, community outreach. We also provide condoms to the health facilities, to the county. Whenever there's distribution, we do that for, HIV and STI prevention, and even for reproductive health, or purposes. So those things are still ongoing, except that, we have, our police from the Ministry of Education, when there are activities, the Ministry of Justice, when there are activities, we can provide the services once, you request. But, intermittently we do, outreach wherein we can provide these, commodities for the people.
Okay.
Yeah, so apart from the budget line that you mentioned from the beginning, do you have other support system to be able to smoothly implement your different interventions?
Yeah, so we have support from the Global Fund and the U.S. government through the U.S. President Emergency Plan for AIDS Relief, we call PEPFAR. And there are other institutions like the WHO, the UNAIDS, UNFPA, the UNICEF. We have Evident Action, and through the implementation with the U.S. government, we have FHR 360. We have Global Reach through JPIGO. We have the U.S. Department of Defense. Currently the sub-recipient of the Global Fund, the principal recipient, we have Clean International. So we have support, but again, all of those grants, you have government co-financing. So it also means that the government providing some form of support also. But again, we have the Global Fund and PEPFAR providing a big chunk of the support for HIV.
Okay, so if you just join us, you're listening to Roadway to Health, an hour-long program brought to you by the Ministry of Health, and we are in talks this morning with Dr. Jonathan Flomo, who is here providing more insights on the different interventions. Liberia's response to HIV. I know you have questions, you have contributions, you have things on your mind right now. So to be a part of this discussion this morning, you can call us on 0775 677 376, 0775 677 376, 0880 514 096, 0880 514 096 are the numbers to call. You can call us this morning and be a part of the discussion. We are still here this morning with Dr. Flomo Melvin.
And we have the online platforms that are carrying this program across the world. Front Page Africa and KMTV and that of and Liberia National Television and the Ministry of Health social media page. They are all carrying this interview live. You are out there, you're watching us from across, so just wherever you can. You can send in your comments and your reactions to the conversation with Dr. Jonathan Flomo this morning. Enjoy, we have a caller.
Good morning.
Good morning. Good morning to my son Melvin.
Yeah.
And good morning to your senior guest. And I also call you from time to time.
Okay, go ahead.
Yes, I want to commend you guys this morning for the topic. And my question to the senior guest is that what I wanted to do, let them keep to the test, like how people can do my level test. As the Bible is not already, let them do the test, like how they can do my level test. When you go to the hospital, you should be able to do the test. So wait for somebody to be, positive before they can keep doing the test. Except you really waiting to say you're going to take my pen or you're pregnant. So that might be this.
Okay. All right. Thank you.
We have another person. Speak with them.
Good morning.
Good morning.
Good morning. Your name and where do you join us from?
Yeah,
Go ahead.
Go ahead. Oh, all right. This person's good.
Good morning. Can you walk away from your monitor?
Yeah, good morning.
Oh, can you walk away from your monitor?
Okay. Good morning.
Good morning. Your name and where do you join us from?
Calling from Mumbai.
Go ahead.
Yeah, I want to know really what are some of the symptoms really that you consider to know really that there's something going on into the body. 1, 2, I would look for government hospital to make sure that every government hospital go for treatment, they should do that testing. I'm
Okay.
going to come and tell you that I want to do HIV test because if people cannot do it that way, as we are saying that men refuse always to have your thing and that will be because they look out for us. So every government hospital you go all over in this country here, they should do testing on you to do you are positive, they will tell you your situation. And before they tell you, they will counsel you as the way the brother said.
Okay.
Okay. Thank you.
Good morning.
Good morning. Good morning, very good morning to the studio guests.
Okay. Your name and where do you join us from?
My name is Franklin Flomo. I call from Banka, Ponkate.
Go ahead.
So I wanted to follow from your studio because that when you go on Google Store, on Play Store, you will see some apps there, and it will tell you you download the app and you put your fingerprint. You can also do your HIV testing. So I want to follow from here whether that is true. Thank you.
Okay. Thank you. So, Dr. Flumo,
Yeah, Doc can
let's
speak to.
respond to the
Then
first set of
we'll take
callers.
another. Yes.
So, okay, maybe starting with the first question, asking about signs and symptoms. So, again, those are things that people ask, and the signs and symptoms, they are not different. We call them the constitutional symptoms. Those things that happen to people who got malaria, or typhoid, as we said. Those symptoms will happen to you. You have the fever, you have abdominal pain. But again, the key one is that you will have unexplained diarrhea, and the fever will be unexplained. You don't know what's happening, but you continue to have that fever. Because, mind you, we are discussing viral. So even if you took antibiotic will not solve the problem of virus. You have to take antiretroviral treatment. So you will continue to have those unexplained diarrhea. You have unexplained fever that is going for long. Then you think, oh no, I think something is going different. I should move because we have the stage 1 and stage 2, stage 3 and stage 4. So up to stage 4. So the one you saw that most people want to see before they say, yes, there's an HIV patient where the person is dry, very lean, and say, oh, that means dry. That means HIV. It means that person is already in stage 4. That we call HIV wasting syndrome.
What's happening to the body at that time?
At that time, all of the opportunistic infections, the body have already been overcome by the HIV virus. So it means that almost like the defense system has been compromised. Like in the football game, they get the 2 defender red card. You see everybody, even number 2 cell can go score because the defense is already weak. So that's the time all of the other infections that have found it difficult to penetrate the system now will have the opportunity because the defense system has been compromised by the HIV virus. So it means that now we have that way TB comes in. First you have pulmonary TB, the TB that has to do with the lungs, the one who just cough. And now in stage 4 you move to extrapulmonary TB. You understand it? So you start having other conditions like cryptococcal meningitis. It's a fungal infection that also affects the brain, but it happens in stage 4. So if we see people come with those conditions, we say no, the person is already in WHO stage 4. So imagine. So those are things that will happen. But again, you see people coming on with skin rash from the beginning, skin rash. They start having thrush. Normally you find children having thrush, but now you see an older person having oral thrush. So those are things that will tell you that hey, something is going on.
For the day or my in the village, what you mean when you say that trust? Like so maybe she maybe seeing something and being taking it to be something different.
So yes, anyway, it's good. So Like, the children you find out wetting, on their tongue. All the way behind the part of the tongue,
Okay.
Yes, those are things you find in children or in adults, you see it happening. If I have fever, the fever after taking antibiotics or taking malaria medication and they say I have malaria, we expect that the fever will go. But the fever can break. Your stomach running, you're not taking all the medicine and you're not working. But you can explain already, I don't eat anything to see, I just have any kind of diarrhea. That's it. You find skin rash, itch coming on your skin, small. It start getting worse. Those are things to check on. You start coughing because you start having, infection now. Because all of the small infection will start finding way now to overcome your body. And what can cause a problem because the HIV will affect the thing in your body, the army men in your body are supposed to fight for you. So when you get some of the small conditions, things just get better because they are in your body fighting. But now the HIV will compromise your system by breaking your entire defense. These cells are there to protect you. They break everything down. And when they break them down, they say, well, I've been finding ways to can't school. I can't school because all the defense system in there, the HIV virus already broke the system. So anybody's on there, go give us saying they can't school. Everybody can come school because the defense system has been broken down. So that's the complication when it comes to HIV. And we don't want that to happen because one of the global goals is that to ensure that, by 2030, can no longer be a public health threat. So we don't want you to move to that stage because we can also do testing, we can do your CD4. As your CD4 continues to drop because the CD4 and your cells are responsible, for your body defense system. So can you imagine we have what we call advanced HIV disease, meaning we test people they have their CD4 as low as below 200. So that's when you see that person gets very, very sick. So we don't want to go to that stage. We want to ensure that people are tested earlier. We place them on medication. I tell you, there are people who've been on treatment for more than 30 years. Except they tell you they have their children who are HIV negative and they are living very, very well with their family. That is the goal, to ensure that we have a healthy population and we provide these services. Somebody said you go to the hospital, with drug tests and things. Except that is something that policy at the level of the National AIDS Commission, the legislature to say, oh no, anybody coming out is maintained to that on a policy issue, a way above me. But what we do is that people have to be counsel, we have to inform you that, hey, we want to do your test because we notice that, we have done other tests, but what we're seeing, some signs and symptoms of HIV, so we want to do your test. You're not selling up based on, maybe you are involved into risky behavior. So what do? You say, oh no, I'm this kind of person, I do this kind of work, because your work also predisposes you, to HIV. So we also, that's the reason we even order your test. But again, to say it is mandatory, that is way above, of my own office.
I also heard people talk about someone's head dropping from the head. It's a sign of the virus.
So, people just come with myth, but, the one that has to do with, people being very lean. For instance, when we were much younger, when we saw somebody coming very, lean, dry, in short, we say, oh no, that AIDS patient there. Because we know that AIDS patient should be looking very dry. But that's not the case. So when you find somebody who is infected and reaching at that level, it means that you are in what we call WHO stage 4. You understand it? Stage 4. So you have advanced HIV disease. You mean your CD4 cell very, very low. Your body defense system is very, very weak. So all of the infection, the opportunistic infection comes and just overtake your entire system because there's nothing there to fight for you. But now we are ensuring how many persons you see coming into conditions because we are making sure we reach the population so that we don't have people reaching that stage.
Yeah, so we are really encouraging testing. It's important that early detection saves life.
And the brother will talk about the app,
Yes.
Sorry, I'm not, an IT person, but those we also see those things. But as part of the WHO recommendation, we follow what is being recommended by the WHO. We are not seeing, those apps and things. Even the testing we do, the test kits, there are several other test kits, but I tell you, Liberia is a country that will follow, global recommendations. So WHO recommendations, we are not seeing those things, but those are recommended by WHO. Yes, we can say you can use it, but for those apps, no. I can't authenticate, the actual results from those apps.
All right. We don't have much time, but let's read something. Let's read some of the comments coming from this the Facebook page of the Ministry of Health. It says, "Thank you." This one is coming from Festus McKean. It says, "Thank you, NDCP and you, Dr. Jonathan Flomo, for the work." Samuel Sewell Hilton says, "Dr. Flomo, thank you so much." And keep up the good work. And so please, Swogan Willie says, please do something about this virus so that we can live in a peaceful environment. And all right, now Ba says, thank you, Dr. Flomo, and it's very necessary indeed. Thank you so much, Dr. Flomo, for talking for the good talking points this morning, and several other persons are on the page, just commenting and just congratulating the Ministry of Health through the National AIDS Control Program and partners. So if we can't get any more calls, what we do, we go to Dr. Flomo to just wrap up and to just touch a few things. Okay, let's take this person and we'll come to a doctor. Good morning. Morning, please go ahead quickly, no time. All right. Thank you so much. I know somebody listens. Yeah, thank you. Yeah, we pray for the person's. For the person's help. Yeah. So sad. Oh, I'm sorry. Yes, so sad. Every day that breaks has its own problem, but God is above. So
yeah, so that Flomo, your parting comments, and then I also wanted to highlight the role that communities play. I mean, the general public play when it comes to breaking the barriers, the whole stigma around this thing that's preventing people from even going to get tested, and all of that, and then your overall parting comment.
Yeah, thank you, Angeline. And we are actually involved with the communities. So I mean, we have. We work also with the community, health workers. We are also working with the community stakeholders. We have, engagement meetings because the community is the one who also drive the response, by the way we interact with them. So we have been in close consultation with the community to ensure, their willingness and their support to the process. So this is something that, we will continue to do to sensitize people so that we can have our community be very safe for us to live. And I also want to say, a very big thank you to the minister and all the entire senior management team for the support. I mean, I'm overwhelmed by the fact that we see HIV and viral hepatitis being captured in the national budget. This is the best way to start. Somebody will say, oh, but the amount is very small. Yes, it is small, but I think this is a significant progress for us as a national program to ensure that we expand our coverage and provide the quality services that our clients need. So another thing is that we work closely with the network of people living with HIV. So we are not just conducting all of the assessment or providing the services in silos. No, we are working with the network of people living with HIV. So there's an entire network. We work with them closely to ensure that they are also part of the intervention. They are part of the community. So we use them also. They go to their peers. They make sure they provide the medication. We bring them for viral load testing. We make sure people come. They are also used for index testing. It will test somebody positive, somebody will cancel. No, even me, you see how I'm looking. I was tested HIV positive. But see me. So don't feel anyhow. You can take your medication, you can be a good person. They are my children. I was pregnant when I got HIV. But this is my child. The child is HIV negative. So you can see a clear manifestation of the kind of work that we do to ensure that we prevent new cases. Another thing, I just want to re-emphasize that I mean, there's no need to panic on the numbers. I think I just gave you a clear picture, and I just want to reiterate again of the 36,000 persons, estimated to be living with HIV in Liberia. Currently, 86% of those people, we have identified them. 99% of them have been placed on treatment, and 95% of them have suppressed viral load, and 75 to 80% of them, their viral load, they are undetectable, meaning even if they have an intercourse with somebody who have using condom, you cannot cause an infection because it's very, very low. So, that's the progress we are making. So it's not just, the numbers are there, but, and then we want to display the rumors of people calling communities and say, the community get 5,000, community get 4,000. No, that's not the case. We don't have our data just aggregated in that form. And I just want to finally close with December 1st. December 1st is the World AIDS Day. So that day, we normally have, we commemorate, the national program, and the team is overcoming disruption, transforming the AIDS response, and then the national team is mobilizing domestic support and transforming the AIDS response. So we want to make sure we rely on domestic resource mobilization. We all know what happened when the U.S. government stop work order. It significantly affected the interventions that we carry out. But so the direction now is for self-reliance and for domestic resource mobilization for sustainability. So that's the reason we want to call on everybody to join us in celebrating that. And we also want to use that platform to launch what we call the triple elimination effort, meaning pregnant women now when they visit the facility, we only test them for HIV and syphilis, because there were children who were coming with some malformation, they were coming with other conditions, due to syphilis. Now we are now detecting syphilis and providing treatment. So every facility you have that available. Now we want to add a second piece, which is the hepatitis B. So when that is launched, we'll be doing HIV, syphilis, and hepatitis B testing for pregnant women.
Okay.
Just as a means of making sure that our people receive quality services.
Thank
you
you
very much, and I'm happy to be available anytime so that we can have this engagement with the public. And thank you, everybody.
Okay, so HIV is not a death sentence. Many thanks to our guest, Dr. Jonathan Flom, for sharing such valuable insights this morning. We have been your host, Angelina N.
Melvin Stewart.
And we have Charles Ardeen, Aisha Yiba. From Page Africa, they have all been here streaming live. Until next Tuesday, have a good day.